I actually am a medical technologist. I'm ASCP certified. I got my certification a long time ago. Graduated in '94 from the Georgia Southern University. I am from Georgia originally, if you haven't noticed the accent. I still have a little bit of that left. I got my degree. I worked for 3 years in a hospital laboratory in Savannah. I worked in chemistry. I worked in hematology, blood bank, did urinalysis, and I did immunology. I really got my start in immunology even at the beginning of my career. I worked there for 3 years, decided to go to graduate school, so I went to the Medical College of Georgia. It's called something else now, but I went to the Medical College of Georgia, and I've got my Master's of Health Education there in medical technology. So all of my degree and all of my education is in medical technology, and here is what we're going to review and discuss. We have to have objectives. How Lyme disease is transmitted. We've already heard about ticks. That's really the only way you can get Lyme disease is ticks. You can't get it from your neighbor. Lyme prevalence, symptoms and stages of Lyme disease, very, very important and very interesting as well. I'm going to try to do some comparison with some other infectious diseases and how it kind of fits in. The two-tier testing system for diagnosing Lyme disease, they've been doing this since 1995. If you look at the CDC website, this is how you diagnose Lyme disease, basically. And we're going to go really, really heavily involved in that one. And the principle and significance of ELISA, which is enzyme-linked immunosorbent assay, or EIA. I will probably use the word EIA interchangeably with that during this lecture. There's a slight nuance difference, but just keep in mind when I say ELISA or EIA, that's kind of the same thing to me. And Western blot assays. And we're going to go in the depth of the principle and how these things are run and actually read. So before we start, I got just a few definitions to give you. Sensitivity. Sensitivity is a percentage that we use for a lot of immunology tests. Sensitivity and specificity may mean something a little bit different in your chemistry laboratories. Have you guys been through chemistry? Okay, well, you may get a different definition, so be prepared. It may be a little bit different. So, but in the immunology world where we're testing for percentage, we're looking at sensitivity means percent who have the disease, who test positive, and specificity basically means percent who do not have the disease and test negative. Now that's very, very important in a two-tier system because there's got to be a balance. You never find a test that's 100% sensitive and 100% specific. They just don't exist. But with a two-tier system, you can get pretty darn close and with that. And the ELISA, enzyme immunoassay, I'm going to use just EIA for that pretty much. So Lyme disease, we've already talked a little bit about. It's tick-borne illness. First, it was described in Lyme, Connecticut. That's not really true, but the first time in the United States that we started kind of realizing there's a specific disease out there was 1975 in Lyme, Connecticut. There were some youths that had these juvenile arthritis type conditions, and it was in a cluster, so they thought it was just kind of, wow, that's kind of interesting that it's right here and all in the same area. And that was what kind of first started thinking about it. Lyme actually goes back way back to the old world, back in Europe as well. I mean, it's been described in manuals. The historic, the rash, the characteristic rash that you get has been described for a long time, for over a century. And so this is just when the United States have really started looking at it. It's caused by a spirochete. Who wants to try to pronounce it? Perfect. Borrelia burgdorferi. Perfect. And you know the guy who isolated the bacteria, his name is Willy Burgdorfer, and he gets to be historical and have an organism named after him. I think it's interesting that if you look up Willy Burgdorfer on the internet, he goes by Willy. You know that a famous scientist, you just call him Willy, like. And it is actually the most common vector-borne illness in the United States. So vector-borne meaning that something gives it to you. In this case, it's a mosquito or a tick. Transmitted to humans by a very one genus of ticks. Dioides species, there's a couple of them that are at the heart of this, the scapularis and the pacificus. It's really a low rate of infection if the tick is not fed for less than 36 hours. Who's had a tick bite before? Oh, from Utah or?
No, California.
California, yep. Ohio, yep. That's a lot of Lyme area. We'll see some statistics in a little bit. I'm from Georgia, so yes, I've had plenty of tick bites over me in the woods. I grew up on 8 acres in woods, basically, in a small town in Georgia. So, I mean, we had them everywhere. So, definitely pretty common. And I'm also going to link at a couple of things here on the CDC website. Lyme disease, you can find all kinds of great information on the internet about Lyme disease. Now, so take some stuff with a grain of salt. If it sounds too weird, it probably is. Confirm it with the CDC website. So if you look at this, here's your ticks. You've got basically, so these ticks, as they grow, they start with eggs, go into a larva, nymph, and then you got your adult ticks. And each one of those have to feed to get to the next stage of maturation. It's just like regular animals. They got to eat and they grow. But each one of those actually will feed on a different animal, with a blood meal. And if that animal has Lyme or Borrelia burgdorferi and is infected, they can actually pass it on to the next animal or person that they feed on. And that's how people get Lyme disease. It's endemic to some of the animal populations that we have. And here's another illustration of how the tick lives. So it starts off with eggs, the larva stage. So it'll actually feed on a mouse or a bird. And if the mouse has it, then it'll ingest it. And it's kind of a carrier situation. So I don't know if the ticks actually get Lyme disease, but it's a carrier. And you can see it goes through the different seasons of the year. The nymph stage, then it attaches to usually larger animals like a deer or humans. And even the adults will attach as well until they lay eggs again and starts the whole cycle over again. Anybody have any questions on that? It's pretty cut and dry on how they do it. So one of these animals, so if it's in the nymph stage, it attaches to a deer, and that deer has been infected, it will pass it on to the next thing that it bites. So it'll detach itself, grow a little bit more, and then attach itself to another animal. And let's see here. And if you look at the CDC website, there's like a ton of stuff for Lyme disease. It talks about the transmission, signs and symptoms. And we're going to go over all that. But I wanted just to show you a couple of things here. Treatment. Let's look at some of the statistics. So this is the most up-to-date stuff on the website. So these are cases of Lyme. I'm going to leave that one and go to... Nope, that's not the one I want either. Cases. Okay. So here's one. Here's reported cases of Lyme disease by year in the United States, all the way from 1995 to 2013. And 1995 is when they first developed the two-tier testing system for Lyme disease. They've been really tracking it since then and even before. Now you have confirmed cases and probable cases. Why do you think there are probable cases versus confirmed cases? What's that?
Get better, or you don't report it?
You don't report it. It's actually a multi-system disease, and it actually mimics a lot of other things it could actually be. So keep that in mind. There's been a lot of talk about chronic fatigue syndrome and stuff like that, but it really mimics a lot. It's a multi-organ disease. It could be looked at as something else. So you can see it just keeps continuing to get higher and higher as we love to go outside and hike in the woods. Now here's something that's really interesting by sex and age. So you can see that 5-year-olds and to 10-year-olds are at the highest rate of Lyme disease. I'm not 100% sure why. I could only imagine that they're just not as self-aware of having a tick And if your parents don't, oh, go ahead. Yes.
With my kids, they're the ones that go through all the brush. They don't go around it.
They go through it. Yep.
And it seemed like that was that way when I was growing up too.
Yep. So in the brush. Now right here around 45, there's another little peak. I don't know if they're out hiking more often, if 45-year-olds are out hiking more, I don't know. And also, one thing that I noticed right down here on the bottom part of this, women, all of this males actually have more cases than women, except when they get older down here. Around 70, they start to kind of inch above men, and I wonder if that's because women live a little bit longer. I don't know. I think that's very interesting, though, to look at the data. Like, men are more prone to getting Lyme disease, and I guess maybe they're more prone to go out in the woods and go through bushes or something, hunting or whatever they do. But then up here, around 75, 70, women start to kind of inch above them a little bit. And let's see here. Cases per month. So what does this tell you about Lyme disease?
Summer.
You get it in the summer. That's when the ticks are out. That's when people are out hiking. If you looked at the life cycle of the tick, it's kind of a little bit more dormant in the wintertime. But yeah, May through September. And that actually mimics our testing volume. So I said that we have typically a higher volume in the summertime. Sure enough, around April, actually it's usually probably maybe around March or so, we start seeing an increase in our volume in Lyme testing. And it does peak in June and July and then kind of levels off a little bit in November. But we do Lyme testing year-round. I mean, we do a pretty good volume year-round for Lyme testing because at ARUP it's a regional laboratory. We get samples from all over the United States. We got people that are hiking in Europe. People that that travel into endemic areas in the Northeast, it happens, and we see a lot of that, even outside the normal range. So this is going to be an interesting one right here. So this is where you can kind of see where all the Lyme cases are. How safe are we in Utah? There's a few. You see the little pockets here, over here on the west. That's you. You're the one dot right there. But most of it is on up here in Wisconsin, Minnesota, and then you got the East Coast, the Northeast. It's everywhere up there. Even in Georgia, my home state, you don't see it that often. But again, yes.
Why is it more prevalent on that side? I know for the west you go, I feel like there's more like deer and stuff like that, whereas like the East Coast has more like population. Like,
yeah.
How are they getting it?
Well, they actually have a higher number of ticks in wooded areas up in the Northeast, and over here in this area. You'd be surprised how much wooded area you have, even on something that's the East Coast like this, and where the deer ticks and where the mice give it to the tick. It's more prevalent. Those are the two hot spots, though, that we always see. And if you were to go back, there's actually cases every year, and you can go back every year, but it's the same map, basically. You'll see the exact same map. So I won't go back to all of them. I'll just let you know that they're all the same. So here's 2013, and I'll go to 2001. You can see that there's less number being reported in 2001. I think there's more awareness of Lyme disease since then, especially when they try to link it to all these other conditions that may not be Lyme related here. There are Borrelia strains in Europe and Asia, Garnii and Aphelidzi. I always have trouble pronouncing that one. They're the same genus, though, different species. And again, we need to learn how to detect those as well, not just Borrelia burgdorferi, which is pretty exclusive here in the United States. We need to test for the other ones as well because we have people traveling so much. 1995, the CDC recommends a two-tier system that we still have today. So what is that, 20 years? Third? 19. So they created and recommended this two-tier system, which they have today, which we do our testing in our laboratory at ARUP. And it is an EIA, a polyvalent conjugate, and a Western blot, IgG and IgM, and we'll get over that a little bit more detail in the lecture. And as I said, there's an array of clinical systems. It's a multi-organ disease. You might think you have something else. There's a list of, actually I found a list on the internet of things that people confuse Lyme disease for. So they got fibromyalgia, mental illness, depression, rheumatoid arthritis, multiple sclerosis, chronic fatigue syndrome. I mean, they've linked this to a lot because it's such a multi-organ system, and and you may or may not have each of the conditions that we'll go over. You may have some of them, but not all of them. The stages overlap one another. So it can be pretty tough to walk into a doctor's office and say, hey, I've got a little arthritis symptoms, and they may not know. If you don't have a tick bite or didn't know you got bit by a tick, you may not know. And then there's 3 clear stages of disease, or fairly clear. They're overlapping, so I won't say they're super clear. Now this is off the CDC website. Can you guys see that okay? Is that too blurry? I was worried that wouldn't turn out very well. So we start off with a Lyme enzyme immunoassay, or an IFA, an immunofluorescent assay. And we're going to talk a lot about the methodology of an EIA here in a minute. And if you get a positive or equivocal result, and your signs or symptoms are less than 30 days old, you will do an IgM and IgG Western blot, which we will go over in a minute as well. If you're negative for the initial test for the EIA, you really aren't considered that you have Lyme disease. You might do another test. Sometimes when you get infected with an organism, your antibodies have to take time to respond and to rise. So, you may have caught it really early. But this is right off the CDC website. This is what you should do. Signs or symptoms greater than 30 days. You do the Western blot only. Keep this in mind. I'm going to ask you why in probably about 15 minutes, why you think it deviates right here. So listen up for that. So here's some proof of why we do two-tier testing. This is the culture, and like I said, culture, PCR on skin biopsies, you have a very limited, narrow time to get a positive result. However, the two-tier testing in serology, antibodies can last years and decades and maybe even a lifetime. So it's really being able to test for antibodies is really advantageous over that, even though you kind of get an 81% sensitivity. And what was sensitivity again? That's right, who are positive for the disease and are positive for the result. Very good. So this acute phase right here, 40% sensitivity and 66% sensitivity in the convalescent stage. So that's one of in the stages of the disease. Primary stage, erythema migrans. What is that? You guys have to know what that is. It's a bullseye-shaped, target-looking rash. It's very diagnostic, actually, and it should radiate out from the center of the tick bite. Now, what if you don't have a tick bite, or you don't have a tick attached to you, and you still have a really characteristic bullseye rash? It could have fell off, exactly. Each one of those, remember those 3 stages of ticks? They have to fall. They'll feed for a little while, fall off the host, and then grow, mature, and then find another host. So keep that in mind. It may have just fell off. I don't think any of mine ever did. I always had to rip mine out. So this is pretty characteristic, 5 to 50 centimeters, so it could vary in size. 70 to 80 patients have this bullseye-shaped rash. Keep in mind that means 30 or 20% don't have it. You can actually have a tick bite. It could actually be swollen. But you may or may not have this bullseye-shaped rash, so keep that in mind. This comes into play a lot, especially if you don't know if you had a tick bite or not. The rash appears 2 days to 2 weeks after the bite. And here are some pictures I found on the internet. You can see some of these are bigger than others. You can see how it radiates out, classic bullseye shape. They can be anywhere on the body, wherever a tick attaches itself. Where? On her hip. Ticks like warm, ticks like warm, moist areas of the body. It could be anywhere under the arm, in the groin area, in the hairline. I mean, they attach themselves all over the place.
I know the most common was in the hair.
It may be. I don't know what the most common, but yeah. I have found plenty of them in my hair back in the day. Not in a while. I've lived here for 15 years, but yeah, they will attach themselves really anywhere they can. Primary stage. Now, as we go over the stages of disease, I don't think you guys have talked about syphilis much, but syphilis is another spirochete. And the stages, it's very similar. It has stages, has 3 stages, just like Lyme disease. They don't have similar symptoms, but they do have similar stage structure in the disease process. So think about, you can almost think about Lyme disease and syphilis kind of in the same light as far as stages almost. You get a lot of symptoms in your first stage, flu-like symptoms, fever, dizziness, stiffness. How many people have had flu-like symptoms in the past week or two? I think everybody at work has had it over the weekend. So you can see how common this looks, and it doesn't really present with any specific findings. Fatigue, I have fatigue every day of my life, I feel like sometimes. You know, I have that abdominal pain, headache. I get a headache every once in a while. Lymphadenopathy, malaise. Oh, I get malaise all the time. Muscle aches. So you really can't tell. You really have to go by tick bite, the rash. Those are the type of things that are going to key you into diagnosing this thing. And also in the primary stage, which is very, very important to us because we're going to learn about antibody titers rising and falling, is you get a rise in IgM and IgG antibodies. Who knows what IgM antibodies, just general characteristics? First response, perfect. Yep, they're larger. They're like a pentamer. They have 5 classes on there. What about the IgG? Smaller. The second that pops up. What else? How long do you keep IgM versus IgG?
IgM will go lower.
Much quicker?
Acute phase. IgG is chronic. More chronic.
All right, you guys just explained my chart. Excellent job. So this is actually just a general, this isn't specifically on Lyme disease, but this is kind of just characteristic of infectious diseases. So there's usually a lag phase here, and we'll talk about how this shows up in testing in a minute, where your body hasn't had time to produce antibodies before. And first thing, you get a rise in IgM, and then you get a rise in IgG, and this IgG can last for years and decades. You might have a positive for these. The IgM, however, is like, what was your name?
Brittany.
Brittany said, it'll rise and then fall pretty rapidly. 6 months typically, maybe it'll last out a year sometimes, but very typical. And this is what we're testing for Lyme disease, both the IgG and IgM. Now, if it's treated, your antibody responses go down to maybe even undetectable levels years down the road. However, if you get exposed to the disease again, you might get an amnestic response, which is a huge rise of IgG. All of your white memory cells, remember those from hematology class? They find that antigen again, and they will just explode with IgG, and that's to help protect you. So this is just general how antibodies, so we're going to actually use these antibodies to tell you if you have Lyme disease or not. The secondary stage, and this could be weeks to months after the tick bite, skeletal muscular pain and arthritis, weakness. I get weakness all the time. Large joints, and it mainly affect large joints like the knees. The knees are very typical in Lyme disease. Neurological abnormalities, mood swings, loss of memory. I have that every day. And this is only in approximately 15% of untreated patients. And keep in mind, if you get treated before you hit one of these stages, you're not going to have these symptoms. Or your symptoms are going to be reduced because you get treated early. So remember that. You want to get treated early. I'm one of those people that I don't go to the doctor unless I'm on my deathbed. And I really don't like going to the doctor. I will be one of those ones in the stage 3 and by the time I get to the physician. But keep in mind, I don't fear a tick bite. I've been bit by ticks before and I've never had Lyme disease. So, and plus, but from Georgia. So loss of memory, poor motor coordination, meningitis, so that's pretty severe. Cardiac complications in 8% of untreated patients, usually brief and not permanent, irregular heartbeat, sometimes there's a lower suppression of the heartbeat, mistaken for a rheumatic fever. So again, here's another disease that can kind of mimic Lyme disease. And the tertiary stage, chronic condition, which you can have all of these conditions or symptoms or just a handful of them. They are really, really overlapping. Each one of these stages really overlap a lot, and just keep that in mind. So if you have a stiff neck and fatigue, that doesn't mean you have Lyme disease, obviously. But the more you have, the more likely it might be, as long as you have a tick bite. If you've not been bitten by a tick, you can cross that off your list because you don't have Lyme disease. And did you see how the stages kind of mimic syphilis testing as well? You have your rise and fall in IgG and IgM antibodies. They have neurosyphilis, which is kind of the later stages of syphilis typically. They're both spirochete bacteria, so they mimic each other in a lot of different ways. So now we're going to get down to what you guys are in school for, testing. This is your bread and butter, so we're going to go over this fairly heavily. Testing, culture. We've talked about this a little bit. Directly identifies the pathogen, but it's a slow grower. May take up to 6 weeks. You don't want to know, you want to know you have Lyme disease now, don't you? Yeah. I mean, it's easy to treat. They give you some antibiotics and you know, soon it's over with. Also, there's overgrowth of microflora. A lot of times they take culture from skin lesions or where the tick bite was. And of course, you know in microbiology class, you've got a lot of normal flora on your skin. That sometimes complicates testing for culture. And there's some complicated media requirements that not every place can actually have the right media. And only found in early illness. Remember I said there's a very narrow window. That's your narrow window. I'm going to jump down here to PCR. So again, just like culture, it directly identifies the pathogen. You can test it on different fluids, synovial fluid. We often get knee fluid in our laboratory for testing, for antibody testing. I don't think that that's a great way to go about test for Lyme disease, but we get that every once in a while. May miss the spirochete in blood. Again, very narrow timelines. Now, EIA and Western blot, which is what we're about to hit, you know, we're testing for antibodies, so it's not really the antigen itself, but the body's response. So when wouldn't you have an antibody response? If you're doing, well, if you didn't have it, but what if you had an infectious disease or wasn't, but you didn't have an antibody response? You came up negative on antibodies. What could that mean? They haven't been made yet? Exactly, they haven't been made yet, or maybe you're immunosuppressed somehow. You know, that's one of the factors you have to worry about with EIA testing. Now, if you get a positive culture or a positive PCR, that's pretty explanatory. You've been exposed to that organism before. EIA, when you're testing antibodies, you actually can have false positive reactions. You can have cross-reacting antibodies. So it complicates it a little bit, but I'll show you a little bit how we get around it. So this is our current kit that we use. All of our reagents come in here, and you can see this is a pretty old picture. I took this back in 2003. This is an ELISA. How many people have dealt with ELISA or EIA technology before? 96 well plate format, very standard. So each one of these wells will be a patient result. The first row is usually controls and calibrators, which are in this area. And we are actually going to take a look at what EIA testing is. So antigen are coded on the wells, and so each one of those little wells, like I said, is going to be a patient result. The antigen, so this broad range of Lyme or Borrelia burgdorferi antigen are coated to the well, and I don't know how they glue it, or I don't know how they get it on there, but it stays on there pretty well. We add a dilution of the patient's sera. Now, if the patient has specific antibodies for Borrelia burgdorferi, they will attach to the antigen right here. We wash out all of the unbound antibodies, because you know we have antibodies for other things in our system. We're just looking for the specific ones for Borrelia burgdorferi. That will attach down here in the plate. And then what we do is we add what we call a conjugate. And all a conjugate is an anti-human antibody, but it has a marker on the end of it. Now this marker could be a lot of things, but in this case it's an enzyme labeled marker. It's an enzyme. It could be a fluorescent marker. There's tons of markers out there that we use for conjugates. So this conjugate is actually an antibody to anti-human, so it will bind. If the patient's antibody is still there, it will bind. And then we add what we call a substrate, and we'll make that marker light up. It'll produce a color, and it's actually a pretty cool color. Right here, we've already added a stop solution to stop the reaction, but this is what it looked like after we added substrate. So we're making the marker light up, and you can physically see it. That's one of the cool things I like about immunology, all the colors and all the meanings to these. And after you add stop, it actually turns yellow. And then how do you think we get a result? I mean, you can see that there are some heavier colored wells than others. Have you guys got into that? A plate reader, very good. Beer-Lambert law, you guys have got that memorized? You dream about that every night? A equals ABC, so we have three of the four components for this equation. We have the absorbance of the standard, we have the concentration of the standard, and we have the absorbance of the unknown, but we don't have the concentration of the unknown, and it's simple math once you do that. So we're actually measuring the absorbance. So absorbance is actually shining a white light through the liquid, and when that happens, light is absorbed. The same amount of light does not come out on the other side, and we measure what is not on the other side of that well, and we can actually tell how dark or how colored that reagent is with this simple little equation here. But it's proportional, so the more color you have in a well, the higher the antibody concentration in theory, right? It's not always true, but theoretically that's correct. There are limitations to EIA testing. EIA testing is quick. It takes us about a couple of hours to run a test, basically. It doesn't take long at all. However, it does have some limitations. It has cross-reactions with other spirochetal diseases. Like I said, syphilis. It could cross-react with some syphilis and others. Helicobacter pylori is another one that we see sometimes will cross-react. Does not alleviate, evaluate antibiotic therapy. So if you've given antibiotics before and you had a test right when you were given antibiotics, you may or may not come back positive the next time. It doesn't tell you that you don't have active disease. It's actually the symptoms that start disappearing tells you that you're getting better. You could actually have these antibodies for the rest of your life, on the IgG ones anyway. A negative result does not exclude disease. Tell me why. What's that? The lag phase, exactly. It takes our body about a week or two to start developing antibodies, and we may have. Now I gave the example that I don't go to the doctor until I'm on my deathbed. What if you're one of those people that go when you get like the first sniffle and you go to the doctor, or you get a tick bite? You may come up negative, actually. Your body hasn't had time to react and produce antibodies yet. So a negative result does not exclude the disease. Keep that in mind for any, and that's probably the way it goes for any antibody testing. I don't like to paint a broad stroke talking about testing, but that's one thing you can kind of say is, you know, if your body's not producing it for some reason, you're immunosuppressed, or you're in that lag phase window, you're not going to show up positive on an antibody test. Equivocal results must be retested in 2 to 4 weeks and not evaluated for vaccinated individuals. Now, why would we say equivocal results retest in 2 to 4 weeks? What do you think an equivocal result would be?
May or may not be positive.
May or may not be positive. It means retest, basically. Very good.
The lower end of the reference.
Yep. The lower end, exactly. There's usually kind of a gray zone that we can't say that it's negative, we can't say it's positive. But if you retest it in 2 weeks, the theory is that you would have time for that antibody to rise, and then you would catch it the next time around. C6 peptide, this is another ELISA that we've been doing for a few years that really hasn't caught on that well, but it does detect the European strains. It's also FDA approved. It has a little bit lower sensitivity and no cross-reactivity with the vaccine OPS-A. Who knew that there was a vaccine for Lyme disease? You guys probably haven't heard of it because it's not been available since 2006, I want to say. It's been a while. They stopped using it here in the United States because they thought a certain group of people who had the vaccination would actually start getting arthritis-type symptoms, and they thought it might be coming from the vaccination. So they have kind of stopped using it here in the United States. You can still get it in Europe, however, and we just haven't had any other good vaccine come on the market. Yes?
So, just a question about treatment. Like, if you, the treatment for this, is a medicine they give you just like an antibiotic?
Antibiotic, yep.
So, would they, if they see that you have had a tick bite and you have that target thing, instead of waiting for the testing, like, I guess it's pretty fast now, but like before it was, when we didn't have PCR and stuff like that, would they treat you with antibiotics just to be safe?
It depends. It depends on what doctor you went to. If you went to a general practitioner, they may go ahead and treat. It's really, according to the CDC, it's not necessary unless you have a tick bite. If you have the bullseye-shaped rash and a tick bite, that's pretty conclusive, I think. But if you don't have those two pieces and you're just coming with arthritic symptoms and general stuff, they may or may not. It depends on what, how much you talk to your doctor and how much you pay them, I guess. A lot of them are willing to give antibiotics, probably more so than what needs to happen. I would recommend definitely waiting for the test to come back, unless you had that bullseye-shaped rash and a tick bite. So confirmation testing, this is the Western blot. And the solid phase is about the same as the EIA. The IgG positive, you have to have 5 out of 10 bands, and I'll show you what that means in a minute. And here are the 10 significant bands. You got to have them all memorized for the test. No, I'm just kidding. Or maybe I shouldn't say that, Justin. If you probably should memorize all 10 of them. On the IgM, you have really lesser of a bar here. 2 out of 3 you need to have for IgM, and it's much more specific than the EIA. Why would you want a really sensitive test to begin with? So we went back to our EIA, which is very sensitive, and you have a Western blot test, which is very specific. Why do we want that combination? And remember what the definitions were. Would you rather have a false positive on the more sensitive test, or the first test, the screening test, or on the second test? And why? We want one on the first test, but why would we want more false positives? If you can't get the perfect test, why would you want more on the screening test?
So that you're not letting them catch it.
That's right, so you don't miss it. So you don't miss the disease. And that's why we have the two-tier testing system. Very, very similar with syphilis, a very sensitive test in the RPR, and the confirmatory test is very specific, the FTA, the fluorescent treponemal antibody absorption. So very, very similar. Here is what kind of a Western blot bands look like. You can see all the kilodaltons. They're very creative. They just call it a number. So a kilodalton's a weight, basically. The OPS-A, which is the protein that was developed on the vaccine. And you can see all the other ones that you have on the strip. Here's some real-life Western blots. This is the IgG. This is our control. So number 1 is a positive control. Number 2 is negative, and you don't have anything on there. And number 3 has a reference band. So just really quickly, the bands that you call have to be at least as dark as that reference band right there. Now, I guess you guys, it's hard to see on this screen, but I promise you it was there on the piece of paper when I took the picture. So we've lost some resolution. However, keep that in mind. If it's not as dark as this band right here, you really can't say you have it. But this one, number 5, is actually pretty good. It has like more than 5 bands on it. It has almost all of them. And we call that one positive, POS. Here you have a 41, that's negative. 41 you see a lot of, it's a flagella antigen. So even with Helicobacter pylori, you can actually see the 41 kilodalton band come up. But that's why you have to have 5 out of 10 or 2 out of 3. Other things will cross-react on this confirmatory test. Here's somebody with the vaccine. It comes all the way out here to the OPS-A protein, and it just kind of drags along all this color, and you really can't interpret that, but we let that go out as this patient right here did have a vaccine, and it can actually affect testing. It can actually affect the screening test and have some false positives if you've had the vaccine, so you got to kind of keep that in mind. Here's an IgM. Again, here's your reference band, your positive control, your negative. Everything has to be, and I know you guys can't see it because I can not see it either. But there's a 39 and 23. So here's a positive result, number 4, and then here's some negative. So you have a 23, which are some other common bands that just pop up. So you have to have that high bar. And actually the IgM is really not that high, 2 out of 3. And if you've had another spirochetal type infection, you might have a 41 kilodalton band anyway, an IgG or IgM. So that's one reason why you don't want to just jump to the confirmatory test. The ones that are more specific, you could have actually a false positive. And then you don't know if you've got the disease at all. So keep that in mind. We want the false positives and the screening test, but we want them together, screening and the confirmation. If you jump to the screening, which we have a lot of physicians do, I mean, we actually see that all the time in the laboratory, where they do just, they start off with a Western blot, we have kind of a mild reactive IgA or IgM, and we're like, is that a true positive or is that just something else? It's probably something else. If they didn't do, and we'll sometimes recommend doing the first test as well. Limitations of the Western blot, these are very, very similar to the EIA because we're testing still for antibodies. Negative result does not exclude disease, can't determine therapy, success or failure. Early therapy may present antibody rise. So if you go to the doctor early, the doctor gives you antibiotics, even though you may not have all the symptoms and all the testing done. If they treat you, you may not even have an antibody rise. And that's pretty common with infectious diseases as well. You may not even have a rise in antibody, which would be another reason why you might have a negative result. 41 kilodaltons of flagellar antigen, we see that one all the time. 39 is specific for Borrelia burgdorferi. The OPS-A at 31 kilodalton, that's the vaccine. Then there was an OPS-B antigen, are very specific for Borrelia. And there's many cross-reactivities, syphilis, penta-Yalls, those are all spirochete diseases, leptospirosis, Rocky Mountain spotted fever, relapsing fever, lupus, rheumatoid arthritis, CMV, and EBV and CMV. That's a good list. So keep in mind, that's why we're doing the 2-tier testing. If you were negative on the first one, you wouldn't even get to the second tier. Treatment. We had some questions on treatment. Doxycycline, amoxicillin early in the disease. Treat symptoms. Treat with symptoms and a tick bite. If you don't have a tick bite, if you can't confirm that, they're probably not going to treat you, and rightfully so. Treatment is not advocated after a tick bite, or treatment is not advocated after a tick bite. Just with a tick bite is what I meant on that one. I was confusing myself. So if you just have a tick bite, they're probably not going to treat you for that. There is a vaccine for, like I said, it's been off the market since 2001. It was given in 2 or 3 doses. It was only recommended for people that go out into the woods a lot, hunters, forest rangers, those people. Adverse reactions linked to pre-existing conditions. That was kind of the arthritis that they said that they got from the vaccine. And I don't know if that's true or not, but they discontinued it a long time ago. Preventative practices. Now this is where you guys get to speak up. How do you keep from getting Lyme disease? Don't go out in the woods. What's that?
Tuck your pants in your socks.
Tuck your pants. As weird as that might look, yeah. But you do it riding bikes too. I mean, it doesn't. Yeah, very good. Don't go out in the woods. Tuck your pants in. Why tucking your pants in your socks? Why is that going to help? They less likely to crawl in. Yep. No deer trails. See, I always follow the deer trail. That's the only way to get back sometimes. But yeah, yep. Tall grass. Don't go in the tall grass. What else? After you go out, check yourself. Make sure you don't have any tick bites. If you do, pull them off. Let's see. I think I've got. Use insect repellent. Check daily for ticks if you go out in the woods. Very good. Why light color clothing? Why do you care? You can see the little black dots and some of the like the nymphs and the smaller stages of the tick. They're like ahead of a pin. I mean, they're really, really hard to see. Tuck your pants into your socks. Control ticks around your home. There are some sprays that you can have, and learn the early signs of Lyme disease. Okay, that's pretty much my presentation. Now, you guys are going to help me out. What does it take? Throw some things back at me. What does it take to diagnose Lyme disease?
Tick bite.
You got to have a tick bite.
Positive migraine.
Yep, you got to have the bullseye-shaped rash, the erythema migrans. What else?
Positive ELISA.
Positive ELISA, very good. If you don't have a positive ELISA, it's either means you need to wait a little bit longer or you still don't need to go to a second-tier test. What else? Then do the Western blot. Very good. So I'm gonna bring it up for questions here in a second. So I go to the doctor. I have a tick bite, no rash. But I want to get treated for Lyme disease. What do you think?
Come back in 30 days.
Try again later. Get the testing done. I totally agree. Get the testing done. If the antibodies are there, then the physician can treat, and they can pick up the antibiotics. It's really a simple amount of antibiotics. It's easy to get rid of Lyme disease. There is still some controversy out, however, but it is pretty easy to get rid of quote unquote Lyme disease.